Thank you for the opportunity to speak. I want to congratulate the Aniridia Sweden and also Aniridia Europe for hosting this meeting. It's a fabulous meeting, and it takes a lot of effort. We all appreciate that, and congratulations on this great effort. And the first speakers have already given you a taste of some of the great stuff that's to come. You know, it's been a fabulous start. And I appreciate very much the invitation. You know, coming from the U.S., we have some slight differences in perspective. You'll hear a few things that are maybe a bit of an overlap, perhaps, with the previous discussion. But I think you'll see how it harmonizes in the end, and it's nice to hear the different perspectives. I've been asked to speak about the surgical management of aniridic glaucoma. And I don't have any financial interest in this topic, but I do have some experience with it. So glaucoma, as you heard in the previous talk, is potentially vision threatening. So it is a cause of non-reversible vision loss in individuals affected with aniridia. It's common in aniridia. It's occurring in about 50 to 75% of patients that are affected with this condition over the course of their lifetime. And that's any age can be affected. It's oftentimes occurring in childhood. The median age for diagnosis is 8.5 years. A little bit different than the paper that you heard quoted from India. That's from our previous work, which was published in the pediatric literature some years ago, but I think it's quite accurate. So it often, 50% of the children with aniridia who develop glaucoma develop the glaucoma by the age of 8.5 years. The treatments are oftentimes effective for glaucoma, and that's very encouraging, but what about aniridia? Do patients with aniridia respond as well? And we'll see some data about that in a little bit. Other problems may require treatment. Yes, cataract was mentioned by Amelie, and that's a very good point. Cataract occurs on average a little bit later. Treatment of cataract. Oftentimes individuals are born with congenital opacities, but the treatment on average occurs in the age of 20s, in the 20s, whereas treatment for aniridic glaucoma can occur earlier. So they're separated by time oftentimes, but yes, if they do overlap, it is nice to separate the treatments. Other problems, can occur as well, but we'll really focus on the management of glaucoma and what the outcomes of those studies are. Aniridia is a profibrotic syndrome, very important fact to state up front, because that can affect the results of any surgery in aniridia, and particularly with glaucoma surgeries. So aniridia fibrosis fibrosis syndrome was mentioned by John Freeman, as well as Dr. Tsai and Ed Holland and other co-workers were involved in the study some years ago, but it did show about a significant percent, about 8% of their patients had developed aniridia fibrosis syndrome, which can be a devastating and potentially vision-threatening complication of eye surgery in aniridic patients. So this is a very strongly mitigating factor for us as we think about the possibility of fibrosis and the possibility of perhaps having a vision-threatening complication from any ocular surgery. That does give us a little bit of a different view of how we approach it. We tend to be a bit more conservative, you might say, in general. But when we do have to do something, we have to do something. So oftentimes we do end up having to proceed with some type of surgical management, and that's what I'll focus on in a little bit. This does have direct application, and there's very few studies which have actually shown this, but certainly case reports have shown up, and we've had a recent case report of a patient that had an OMID glaucoma valve failure due to fibrovascular ingrowth into the tube, and so it can occur in our glaucoma surgeries as well, and certainly with trabeculectomy literature, there's a fair rate of fibrosis that limits the success rate there, and you'll see that in a few minutes. But before we get into that, I really wanted to spend just a couple of minutes with an important topic to address before we start getting into treatment of glaucoma, because many times our treatments vary in glaucoma management depending upon what the mechanism of glaucoma is. So for example, angle closure glaucoma is treated really differently than open angle glaucoma, and we just really need to know a little bit about the mechanisms. It was mentioned that infantile glaucoma can be different, and it is different in aniridia. If the child presents at birth with severe glaucoma, that is probably a little bit different category. These patients have been studied. I've certainly had them, And by age 17 or 18, 20, I have nice pictures showing really significant keratopathy in those patients as well. By the time they're younger than other patients on average are affected with aniridia, are affected with keratopathy. So this can be a little bit of a different type of entity almost. And what has been found is that these individuals tend to have a little bit more of a severe congenital anomaly of the angle than the average patient with aniridia who develops glaucoma later. So specifically, they do have the iridotrabecular dysgenesis with an anterior insertion of the iris, and also absence of Schlemm's canal is very common in this group as well if they present with very early aniridic glaucoma. So they have several structures that are important in draining aqueous from the eye that are absent or malformed at birth. And so that is a very different group, very small percentage, fortunately for us. Most common presentation is in childhood and early adulthood, and that is an open angle glaucoma. Really worthwhile to emphasize that because there was a small body of literature that was very influential that was published that suggested that aniridic glaucoma may be a progressive angle closure, which is now becoming clear that that is not the case. And I'll show you the evidence for that in just a moment. Secondary glaucoma, angle closure glaucoma can occur. It's usually after surgical treatments though. In fact, all of the patients that I've seen that have angle closure due to the residual stump of the iris covering the trabecular meshwork, every one of those patients has had prior surgery, which explains that finding. So it can occur, but it's not a closed angle, it's an open angle glaucoma. And this is some of the data that's based on. We did a study a couple of years ago, not too long ago, one study among several that looked at this, and this used anterior segment OCT and gonioscopy combined to try to delineate definitively whether these patients had open angle or closed angle glaucomas. This is about 86 eyes, and the findings were essentially showing that the vast majority of patients that presented with glaucoma had an open angle glaucoma presentation. This just shows you one typical patient. And you can see on this, there's a little arrow, always a nice thing to see an arrow because that shows you the main finding. And you can see there's an open angle there, very clearly open angle by anterior segment OCT. So you can really easily see this, and what you find if you do that kind of study is that the vast majority of patients have an open angle at presentation when they present with glaucoma. In this study, there were a couple patients that had closed angle, a couple. All of those patients had had prior surgery, which likely contributed to the development of the angle closure in those patients. So in our discussion and our concept or how we interpreted these results were that aniridia is a profibrotic syndrome. So if you do have an angle closure and you've had prior surgery, it's not surprising. It's the angle closure is due to the fibrotic response in response to the previous surgery. And that we felt we could see very clearly with the anterior segment OCT, where we saw significant fibrosis in the angle in those patients. So what about this concept of progressive angle closure? I just really want to emphasize this again. This is found in textbooks, and it's just a really, it's an interpretation of some results in the past that led to a big misdirection of this field early on. And there were basically three papers that suggested that there can be a progressive angle closure in aniridia, and not recognizing that it's usually an open angle glaucoma. But in these studies, if you really look at them, every patient in the studies, and these were the same series, essentially they published three papers using the same patients, but they added more patients as they went along. But in these patients, every patient was treated with at least 1 to 3 goniotomies on average. Some got 5. So in the final series, every patient in the series that was entered into this series actually had a pressure of less than 21 at presentation, which is pretty extraordinary for aniridia because, as Emily mentioned, the average corneal thickness is about 630, 650 in these patients on average. So you should have even a little bit higher pressures that you can tolerate. But if you do goniotomies on people under 21 every time, that's a little bit, we would say that's a bit aggressive now. So I think, looking at, and every patient in this series had over 200 degrees of goniotomy before they were entered in these studies. So I think that, we have to interpret those with a grain of salt and recognize that those were not naive eyes to treatment. And so if there was some angle closure in those eyes, it was for a very good reason because they'd had angle surgery over at least 200 degrees of their angle in most cases. So anyway, just to kind of set the level of knowledge about the mechanism of glaucoma in these patients. So now to talk about aniridia treatment, we're not going to focus on medical treatment. There's a lot of interesting work that's been done on medical and laser therapy in the past, but I'm not going to focus on that. I will simply comment that most patients that have aniridia do have medical treatment. It's an important topic. Laser treatment is not generally speaking useful, at least the type of laser that we use for non-aniridic glaucomas. Those types of lasers are generally not helpful. We will mention the special case of cyclophotocoagulation in just a minute, but generally speaking, they're not useful. And incisional surgery is useful. That's been performed, again, on average, in over half the patients with aniridia during their lifetime at some point. And that's from previous work, again, published in the pediatric literature, back some years ago, and I don't think there's been a significant revision of this since. Drainage implants are frequently used in aniridia. Here's a couple of aniridia patients that have had drainage implants. Here's another one, had drainage implants. But you have other options too, and a couple were mentioned. Trabeculectomy. Trabeculotomy is one of the most commonly performed surgeries in the world for infantile glaucoma, especially in areas where there's a poor prognosis for success. In the United States, we have a good prognosis for success, so we usually do goniotomies, but many parts of the world where I've been, I lived for a while in India, I lived for about a year and a half in the Middle East, and in those areas, they have very severe glaucoma presentation and very commonly use a combined trab-trab as an option. So that's an option for the infantile glaucoma. Trabeculectomy with monomycin C is an option, drainage implants an option, and then cyclodestructive procedures, and I'm going to parenthetically say as an adjunctive treatment is an option as well for treatment in these patients. And then minimally invasive glaucoma surgeries, we got to talk about that because that's the most commonly performed glaucoma surgery in the United States now is minimally invasive glaucoma surgery. So if you don't talk about that topic, we're missing a huge area right now. So we're going to talk about these a little bit as we go along here. Goniotomy, not very helpful, especially prophylactic goniotomy. Let's just say that we're all reaching a consensus on that. Therapeutic goniotomy is not effective, and that's from many papers that have discussed that as well. However, we do have that strange variant of goniotomy, which is angle surgery done ab externo, which is the trabeculotomy. And that's the one, this is the same paper that was mentioned by Emily, so I won't go over this too much. But that's a bit of an outlier in this field, isn't it? So we can, take that into consideration. We have some that have had some success with trabeculotomy. However, in the big picture, looking at angle surgery, not a lot of success in the literature with that. And then infantile glaucoma, as I mentioned, is a very unique subset. This is a child that, presenting shortly after birth, very similar picture. And as was shown by Emily, very similar outcome. At age 20, I have pictures of her with opaque corneas bilaterally from the keratopathy, almost identical. And this patient had severe anomalies of the angle and markedly elevated intraocular pressure at birth. And so we did do an Ahmed valve, a pediatric implant, which had to be replaced later with an adult-size implant, but she had good control of her pressures, nonetheless had severe vision loss due to corneal opacity in both eyes due to the keratopathy. So the pressures were controlled. Sorry, I can't see you over the monitor. But pressures were controlled, but, not the best visual outcome because of that. Now, what about trabeculectomy? Okay, so here's the entire literature on trabeculectomy related to aniridia. And you can see, we don't have to go over each paper, but you can see that generally speaking, if you look at the right-hand column and look at the percent success for all of these papers, you can see that the percent success is not very high. It's not acceptable to us to be doing a procedure that has a 0 to 20%, a maximum 36% rate of success in literature when we have other alternatives that are better. So I just want to mention this to say that there has been some experience with trabeculectomy with monomycin C now that has been published. We've had experience as well, and generally speaking, the outcomes are not very good. So we're going to move on, right? So drainage implant surgery. Patients develop an elevated intraocular pressure. Sometimes we've got to use drainage implants in certain situations where there's a poor prognosis from success with the other alternatives. So we use drainage implants very frequently in aniridia. Here's the entire literature about drainage implants. And if you, again, just look over to, these are generally small series, as was mentioned by Emily earlier, small series of patients, usually less, 10 eyes, 5 eyes, 3 eyes or whatever. But the success rates, if we look at that cumulatively, and I'm actually kind of keen to do a meta-analysis at this at some point, but I don't have to because I've got another study I've done I'm going to show you. But if I were to do a meta-analysis, you'd see that the success rate overall is pretty good. If you look at the column on the right, ranging from 67% to 100%, let's say the average is in the 80s, that's pretty good. So here's that one study that was the only study we have that's a comparison of trabeculectomy versus drainage implants, and so therefore it is useful. Very small number of eyes, but it's a comparative study, and it shows how do drainage implants compare to trabeculectomy. We know the literature isn't that great on trabeculectomy, and we know the literature is pretty decent on drainage implants, but if you do a head-to-head comparison, how do they actually compare? And this is the only study that shows that. It's a very small study, again, 18 eyes, drainage implants, 12 eyes, trabeculectomy, but it was a comparative study, and there's the result. You can see that there was a statistically significant difference on the success curve, which is a fairly powerful statistic, which is p less than 0.05 for the log rank test, when you looked at the difference in the surgical success in comparing trabeculectomy to drainage implants. So we can say that it appears that with the literature that we have, that drainage implants are more successful than the trabeculectomy in this population. So what about keratoprosthesis? This is just a mention, just because I've had a lot of experience. I worked with Klaus Dollmann to develop the original device. And so I did the first 150 patients with Dr. Dollmann, and this culminated in this paper in Ophthalmology in 1998, which showed an 81% success rate of drainage implants with keratoprosthesis. And I would comment that that's the only series that was successful, and the reason is because 100% of the patients develop glaucoma after keratoprosthesis. So if you don't do that, you will not be able to achieve success. So that was the trick that finally got that procedure to be successful, was the use of drainage implants at the time of surgery or after surgery in those patient populations. So it's a group that where sometimes we see that in aniridia, and there have been some case reports and other things with aniridia that are the same as the previous literature on glaucoma in general after keratoprosthesis, showing a pretty good success rate with drainage implants. So here is a new series that I've just presented this at American Ophthalmological Society about 2 weeks ago, AOS, and I'll be publishing this soon, but you're seeing it first. It's the largest series, I could buy 2 eyes, in the literature. And so it's a retrospective consecutive case series done from the time when I could get sufficiently long follow-up and had the medical records access to be able to get a follow-up past 5 years. So all of these were treated with FP7s. We did have 7 eyes that were treated with sulcus tubes, a little bit more posterior, sometimes more at an angle, as Emily mentioned. 5 eyes with flow restriction sutures, and 2 eyes that had prior surgery. So this is actually a primary surgery study of people treated primarily with drainage implants. And we define success as pretty rigorous, definition there, including a % reduction criteria and an IOP threshold. So anyway, here's the result. So it showed that the mean intraocular pressure was reduced in these patients in general, p less than 0.0005 at all time points after surgery with a follow-up of up to 7 years. And the number of medications was reduced by p less than 0.0005 at each time point compared to the baseline for up to 7 years follow-up. And then here's the success curve, and again, pretty high success. Now, I was surprised to see this result myself, but I didn't know. I mean, the fellows collected the data, so they're usually pretty accurate. So I think, so I didn't directly write down the success or not. They decided, and they felt that it really is successful. We had a 95% success rate after 7 years, so I think it can be good. The one failure did have a micropulse CPC as an adjunctive treatment. And that's the one exception I wanted to add to Emily's comments, which were quite good on this topic. We agree that we both agree that there's no usefulness really to doing primary therapy with cyclophotocoagulation. However, with an adjunctive use, if you have somebody who has a drainage implant, they have a high pressure, it can be very useful. So the one patient that quote unquote failed because they got an additional glaucoma procedure, which was the micropulse CPC, did have a controlled pressure and no complications. So, the clinical success rate of this study was very high. So, but we did have one failure due to a treatment with micropulse CPC. The complications are listed here. This is everything that was in the charts for complications. We did have 4 tube repositionings, 1 patch graft. So there are some tube issues that kind of clear up after surgery. The transient choroidal effusions were transient, non-vision threatening, didn't require surgery. And then there was 1 patient that did have a cataract surgery, but it's hard to know in that patient whether it was due to the drainage implant or not. So generally speaking, the conclusion of this study was that Ahmed valve or drainage implant surgery is effective for controlling intraocular pressure in patients with aniridia glaucoma. Complications are transient and non-vision threatening. That's my new procedure, my new institution, by the way, EVMS, just to give a plug. I am moving from UVA to the other state institution in Virginia, which is Eastern Virginia Medical School, right on the water. And so I'm excited about that. I'll be moving there next month as chair of the department there. So cyclodestructive, I don't want to belabor this point, but there was only 1 paper really that's been published on aniridia, 25% success, and also in those patients that quote unquote had a successive reduction of IOP, they had complications. They had ptysis bulbi and cataract in many patients with that. So we don't find that to be helpful, but we do find adjunctive therapy useful. In our hands and in others, it's about a 70 to 75% success rate, including up to 2 treatments with micropulse CPC in patients that have an Ahmed valve used as an adjunctive treatment to try to get better control of the pressure if they have a little bit of a rise of pressure after a drainage implant. So it's interesting when about to write a paper, so I'm about to write a paper on this, and I went back through, I looked at the earlier papers, and I really read them, and for the first time in a while. And Karim Tomi is a really brilliant Lebanese ophthalmologist who I've known for most of his career, and he wrote this paper some time ago, and he really got it right back in 1992 with a very small series. He found that drainage implants, he used Maltino, was successful in 83%. Trabeculectomy only had a 9% success rate. Cryotherapy was 25% successful, but it had ptysis and very worrisome is the ptysis bulbi, which is, you lose vision in the eye, you can't get it back. And goniotomy and trabeculotomy was unsuccessful once glaucoma was present in any of his patients. So I think, going back to the literature, I just wanted to give a shout out to this one paper that I just reread, and he really did sort of get what we're kind of moving towards now. MIGS, I did mention that we do have to talk about MIGS. MIGS are now the most common glaucoma procedures done in the United States for glaucoma. So, how does this relate to aniridia? What are we doing in that area? It's a very important area. So, angle surgery has many options for MIGS, many options. And so we can do iStent, hydrohysterectomy, KDB, many things. GAT, you saw the ABIC, being done in the other talk by Emily. Transscleral MIGS, that's a different category, where you shunt the aqueous across the sclera into the subconjunctival space. There's right now at least 2 in the United States that are available, and I don't know about Europe. But we have the Zen-Gel stent and we have the PreserFlow, and those are an option as well for minimally invasive glaucoma surgery. You see the bottom panel shows a Zen, I'll show you here, this one has a Zen stent being injected into the subconjunctival space, and minimally invasive procedure that does cause transscleral filtration. And then we have choroidal shunts. We used to have one called CyPass, but it's been removed from the market. So we now are waiting for the Miniject, and that'll be a choroidal shunt that we should find, quite useful. And we certainly will be trialing this in aniridia when it becomes available. So here's a paper that we're, sending off now. It's kind of preliminary work on Zen. Well, no, not sending it off now. We're going to get a few more patients in this. But Zen versus KDB and aniridia. So one is goniotomy, KDB. One is the Zen, transscleral filtration. The Zen is the one with the dotted lines and the circles, open circles. So the Zen did significantly reduce the intraocular pressure at all time points. The goniotomy did not. It transiently reduced the intraocular pressure for about a week. And then after the 1 month time point, the pressure was not significantly reduced compared to baseline. Number of medications, very similarly, was reduced for about a month after goniotomy. And then the number of medications went back up to baseline. And with the Zen or transscleral filtration, we found that it was more successful in reducing the intraocular pressures. And this effect was sustained over the period of follow-up for the study, which is only 1 year. So we're going to extend that follow-up and have more patients in that when we publish it. So the success rates were quite different. The Zen was 100%. We haven't had a failure yet. And then with transscleral filtration, whereas with goniotomy, we were down to 30% after 5 months, and I'm sure that the success rate will go to 0, at some point pretty soon. So I think this was significantly different, p less than 0.03, between the two groups. So there is a statistically significant difference already, and of course we expect that this will be even more dramatic as we extend the follow-up on this study. So goniotomy with KDB trabectome is not useful in primary surgery in aniridia, whereas transscleral filtration with a Zengel microstent is a promising option for primary surgery in aniridic glaucoma. It's minimally invasive. It doesn't have as many complications. Putting in a drainage implant is a fair amount of surgery. So kind of what we're thinking is we may be able to have a minimally invasive option as a primary surgery where the patients can tolerate the procedure very well and not have a lot of complications. And then we always have the drainage implant surgery, which is a little bit more involved and more recovery for the patient, as an option that will be successful if that does not work. Now, we have published this paper about comparing goniotomy type procedures with Zengel microstent or transscleral filtration in patients that have glaucoma. This is not aniridia. This is all patients that we've treated with this. And this was published in 2022. Is this okay to use? It's okay? Great. The success rate of eyes after the Zengel microshunt was significantly different if we made the IOP threshold criteria for success lower. So if we wanted to get a pressure of 12 to 14, which is nice, to get a lower pressure, then we were more likely to achieve that with the transscleral filtration than we were with the goniotomy. So the main difference for us with regular adult glaucoma is that if we use a transscleral microshunt, we are more likely to get lower pressures. So that brings us to this. If we have a patient that has a lot of damage, we need to get a lower pressure on average, usually, ideally, mid to low teens. And so the transscleral filtration options are an option to be able to achieve that goal. Whereas with the standard goniotomy procedures, even in individuals not affected with glaucoma, we still can't achieve that range. So it's a good option that's emerging. I think having these MIGs that are suitable for different patient populations. This is for more advanced glaucoma, but for aniridia as well, we've found that our early results, we're going to strengthen them up before we publish them. Our early results do indicate that the transscleral filtration is more successful than the goniotomy-like procedures. So in conclusion then, aniridia is oftentimes associated with glaucoma, which can cause progressive vision loss, and we of course need to avoid that because it's irreversible vision loss once it occurs. Open-angle glaucoma is the most common mechanism. I wanted to emphasize that because there's old literature which we can't seem to move on from, and so we need to know where we're at now. And glaucoma drainage implants are effective, and other procedures can be useful. And we are very keen on MIGs at the moment because this is very promising in aniridic glaucoma, especially the transscleral filtration MIGs. So I would like to take this opportunity to thank and congratulate Aniridia Sweden. What a great conference. And I know it's a lot of work, and I'm most appreciative for the invitation. Aniridia Europe, congratulations. What an incredible conference. And I'd like to thank my colleagues in the US, Aniridia North America. I am thrilled to be part of that organization and, on the board, and we have an incredible board, most of whom are here today. Grayson and Sally are representing Vision for Tomorrow. IWSA, the Wagger Group, represented by Shari and Kelly Trout. Many of you know them, and then Aniridic Family, Janelle Collins. It's just a great group, and we have a great board, and we're very proud of it. So it's nice to collaborate with Aniridia Europe. I want to personally thank my patients and families. I follow a lot of patients with Aniridia, as you probably know, and my long-term collaborators, one of whom is about to give a talk today, Dr. Jim Lauderdale, Dr. Rob Granger, Dr. Xiaorong Liu, and Dr. Hao Zhang are working with me now a lot on imaging techniques, Viz OCT, which is a high-resolution OCT technique that we're very excited about. So I'm really grateful to my collaborators. Anyway, thanks to Aniridia Europe, Aniridia Sweden, and ANA as well. So many thanks to you all.
So thank you for this very comprehensive presentation. I'm not a glaucoma specialist. I do mainly cornea, but so I had a question. You could perhaps elaborate a little bit. It seems that the big problem in this patient is the fibrosis syndrome. So it makes sense to me that you get such good results with the XEN, the little like device that, if I understand correctly, doesn't interfere with the conjunctiva and the ocular surface. But how would you explain the much better results of the valve as opposed to the trabeculectomy? Because in both those cases, you interfere with the conj somehow.
Yeah, it's a great question. I think, you hit on the great point. Well, our theory is that we don't know, but our hypothesis is that it's a little bit less disruptive to the eye, so less inflammation. Patients can look pretty good in the post-op period for the XEN, the transscleral filtration. It's minimally invasive. The tube is a little harder to explain. I think the idea with the tube is that, you do get a capsule or a, depends on what you want to call it, pseudocapsule, I guess. It's encapsulated around the implant itself, and that capsule may be a bit thicker in aniridia, I don't know. It may be different in aniridia, I don't know. But the end result is that that's one of the parts of the design of the implant, which was, all the way back to Maltino's days in the 1970s, 80s when he was developing it, hypothesized that having that plate is the key thing for the drainage implant success. And you do get it encapsulated, but even so, over time, the aqueous can drain through that capsule. Sometimes you get a bump in the pressure early on, and I haven't noticed whether or not aniridia patients have a bigger rate of the hypertensive phase after drainage implant surgery. Maybe they do, but ultimately the success rates are pretty good. So I don't have a great answer for that. It's a great question. It's really pretty key to the whole thing, but we have not been able to link any problems with the fibrotic mechanisms to failure in that group yet, although I suspect over time we'll be seeing differences that we can link to that difference in the patients.